All right. Here we are, back again. Sean Allen here in Chicago. We'll be in the studio here with Ivo in just a moment. We're back for podcast number 124. We took a couple weeks off, chilling out, trying to recuperate a little bit and get some new things on the go, which we're doing this weekend. Ivo and I are going to be offering a little online educational stuff. No more having to pay for online CE at another site. We're going to try and do something live, and we're experimenting this weekend, so that's going to be exciting. And it'll be limited numbers, so the first guys that sign up will certainly get first dibs. And for the people who, once Patreon is up, for people who are Patreon donators, will obviously get first dibs on that. So if it's something that you guys want to look forward to, a small donation on Patreon will make sure you're at the front of the line. But we will eventually be finding a way to add more and more spots for this. So this is something exciting. We want to be able to expand our dialogue to you guys on clinical cases, looking at videos. So hopefully this will allow you guys to just basically sign in to a site. You'll see everybody else there, and you will see some videos, and Ivo and I will be talking in your ear, and you guys can ask questions, and we'll make answers, and we'll rewind the video and try and teach from a virtual studio. And so it's going to allow some folks to really hopefully get a lot more deeper information than they have been getting from our blog posts, because let's face it, hands-on time with Ivo and I on a case is where a lot of the learning really starts to come together, because your questions, your specific learning curve problems can come to the forefront, and we can offer you guys a deep insight on that. And let's face it, if you've got a question, probably someone else in the room is going to have a similar question or learn from the answers from that question. So it'll also allow you guys to send us your videos and upload them, and we can talk about them that way. Again, we won't make any diagnoses off of there. We will remind you that what we see on a video is not your problem. It's how you have learned to compensate and move through your problems. So without the physical exam, we can't make an accurate diagnosis or throw out a remedy, but we can certainly talk about things and things to consider, and then you can take this information back to your therapist, your coach, your trainer, and they can then do the clinical exam to look for these issues. And hopefully then you can invite them into the platform, and they can learn from it too, or at least understand your case a little bit better. So I think we're going to offer something that is going to help a lot of people on a lot of levels. So that's going to be really exciting. So even more exciting than not having commercials, right? So we've got a great show lined up for you today. First of all, Ivo's, I thought I'd just mention, I don't think we've ever mentioned this. Ivo's business website is Summit, SUMMIT, Chiro, and rehab.com. Mine is Dr. Allen, DoctorAllen.co, not .com.co. I also have a personal website, Sean Allen, that's SHAWN, Allen, SeanAllen.net, where I have my writing, my art, some other medical stuff up on there. So that's just kind of personal stuff. You're always welcome to have a look at there. I'm going to be doing a new athlete series on my art studio over there, so that's going to be something that you could look forward to. Maybe you need some artwork for your office, for your studio, for your gym. So maybe. Let's see. But anyways, we've got a great show lined up for you today. I mentioned the Patreon. I mentioned that we're back now. We took about a month and a half off. Ivo and I needed to recharge. And so we're going to get back on the 2-week schedule again, which will be really good for us to be on a schedule again. And I'm sure you guys will appreciate that as well. Hey, Ivo and I are going through a little bit of technical changes on the podcasting. There's a little bit of feedback on Ivo's mic this time. It may just be background noise in your ears. Apologize for that, but I couldn't edit it out. So I did the best I could. But anyways, we will try and get that cleaned up next time, so I just wanted to apologize for that. Also, we're going to rehash Elon Musk and his neural lace. There's been some updates on that, and I thought I would throw that in there because we're talking about neurodegenerative diseases and the possibility of using the neural lace to circumvent those neurodegenerative diseases, which are obviously gait-related, and that's why it's here on the neuroscience piece. And we're going to go into kidney problems in runners, and it's marathon season, and people are starting to occasionally see a little bit of Coca-Cola coming out of their urethra. And it's not Coca-Cola. It's kidney problems. So go and see your doctor. If you've got Coca-Cola, your little Coca-Cola dispenser, your own personal Coca-Cola dispenser, you might want to go and see your doc. Make sure you hydrate properly. Watch out for the heat. We talk about that in the podcast. So we also talk a lot today about posture, about functional leg lengths, about orthotic posting, and some of the mistakes Ivo and I made early on, posting orthotics and putting cork posts underneath shoe inserts and footbeds, and then the mistakes led to epiphanies, which led to better answers and understanding clinical injuries and creating injuries and solving injuries or problems. So this, I think, is an important podcast for a lot of people to hear, because there are a lot of tinkerers out there with not enough medical background to be tinkering, but hard to judge, because Ivo and I did that too with a medical background. So slap us twice, because we're hypocrites, I guess. But anyways, I'm glad that you guys are here. I hope you find this show very interesting. We certainly enjoyed it, and welcome back. We're back on the 2-week cycle again, so it's good to be back, and we hope you guys enjoy the show. No commercials, a little bit of band music just to set the tone, and we will see you on the other side. Ivo and I are going to free talk it today and just talk about a couple of things and maybe a case or two. Someone emailed us just at the last minute, and I thought it would be worthy of just throwing in there and seeing where we go with it. But this one just came up the other day, and I thought it was worth mentioning since we're entering into marathon season. We've talked about these things over time with, what do long-term races and heavy mileage week after week do to the heart? Well, there's a new one out of, let's see, fairly reputable journal here, the American Journal of Kidney Disease. And this one is a little scary. They took 22 runners out of the 2015 Hartford Marathon, and they found that 82% of these participants displayed stage 1 acute kidney injury. And as we know, kidneys are kind of important. And if you're at the end of a long run, a marathon or an ultra run, and you start peeing dark stuff that looks like Coca-Cola, hope that it's Coca-Cola, because it's probably not. But make sure you hydrate as best you can. But these guys, 82% showed some signs of stage 1 kidney disease, or kidney injury, not disease. I don't want to go that far, because most of these people recovered within 48 hours. But you can imagine doing that kind of mileage on a repeated basis. Tissue tends to change after a repeated pathologic loading. It does in muscles and tendons and bone, and it probably does in kidneys too. So I don't know if you panned over to the study or not, Ivo, but here's the meat and potatoes of this, and then we'll hear what Mr. Neurology and Physiology has to say. But they took 22 marathon runners from that Hartford Marathon. Mean age was 44, and 41% were men. 82% of the runners developed an increase in creatinine level equivalent to AKIN, defined acute kidney injury stages 1 and stage 2. 73% had microscopic diagnosis of tubular injury. And there were some other serum numbers that were off, urine albumin, which were biomarkers. And they all peaked on day 1 and were significantly elevated compared to day 0 through day 2. There was some recovery after that, but serum creatinine kinase levels continued to significantly increase from day 0 to day 2. So all this distance stuff, it's great in some respects. We talked about it earlier this week on social media about running 2 times a week, or an hour. Was it an hour twice a week would increase return several fold lifetime days. I don't know what the numbers were exactly. Maybe you remember, but there's benefits and there's drawbacks to everything. And here's a drawback. What'd you think about this?
Well, I mean, looking at the study, first of all, like with any study, you have to take everything in context. So what they did primarily to look at kidney damage was look at creatinine levels. So creatinine is a breakdown product of creatine phosphate, which we know is something that builds up, and it's used basically for the explosive type initial movement during high intensity sorts of activities and things like that. So those levels were measured, and what happens when we have creatinine levels that are increased in the blood, it generally indicates some degree of renal tubular damage which has occurred to a small degree. They also measured 6 different injury urine biomarkers, particularly IL-6, IL-8, and TNF-alpha, which are going to be increased in any inflammatory state, not just with kidney problems. So we would all agree that running, particularly for longer periods, particularly since your carbohydrate stores, even if you carbohydrate load, are not generally going to take you much past the 2-hour mark, and possibly less than that. You're going to have to go through breaking down other things, and some of those things will include fat, but they also will include protein, and breakdown products there are going to result in some degree of inflammation. Small amounts of increased inflammation or creatinine levels post muscle damage of any type are normal, and all they're saying is that it's kind of overwhelming the kidneys. So part of it, yes, may represent renal tubular damage, but part of it might just be you've exceeded the capacity of the kidney to be able to filter that out. If we think about creatine phosphate, it's one of the 3 energy systems. We have the aerobic system, the anaerobic system, and the creatine phosphate system in muscular metabolism. So if we're increasing the amount of creatinine, which is in the blood, part of that's going to just be as a result of muscle damage, which occurs as the result of almost any exercise, provided that it's, vigorous enough, but anything that's going to build. And the inflammation and breakdown is part of the repair process as well.
Mm-hmm. Would you say that this is magnified in, heat intolerant states, or obviously dehydration states, but are those factors as well from what you're aware of?
I'm not sure about heat, but heat generally tends to speed up reactions, and if we increase our basal body temperature and our core temp goes up, it would stand to reason that you'd get an acceleration of some of this. Generally speaking, dehydration is way more of a factor as far as that. And here's the problem. Your body can absorb approximately, and again, these are just rough numbers, about 24 ounces of water per hour. Okay? Maybe some people could do a little more, some people could do a little less. If you're using a little bit of salt, like 75 milligrams, per liter, you may be able to get just a little bit more because you shut down the ADH mechanism for peeing water out and things like that. We can sweat, particularly in high temperatures, up to 3 liters per hour. So if you're going to be running a marathon or something, at some point, pretty much you're going to be in a dehydrated state at some point in the race. For some people, that'll occur earlier on. For some people, that'll occur later. People that do a lot of gels and goos and things like that. And you're not careful of your carbohydrate to protein ratios. You're going to see increased, basically, glycosuria. You're going to see increased glucose in the blood, and that's going to cause increased filtration, and we're going to have more intracellular dehydration, which is going to occur to try to dilute the extracellular compartment. So there's a lot of factors here, and I think, as is typical of the media, it's a little blown out of proportion. We could have done the same thing and said it about weightlifting, and other exercises which are out there as well. So.
Mm-hmm. Yeah, it's it's really no surprise. It does take time for this thing to kick in, and it's why you don't see these problems, in sprinters or in cross country runners. It's the heavy mileage events during a short or a specific period of time. So We see so many of these problems coming in the latter stages of a marathon, 15 miles plus, where people are having problems regulating, their fuel. They're regulating this kidney function problem, fluid levels, dehydration. It's why these people look so terrible at the end, and it's why some people don't make it to the end, and unfortunately meet a demise that none of us want. So, just another thing to kind of plug in the back of your head. Make sure you're hydrating properly, and if you don't feel well, there's no need to be a hero here, especially on a hot day or a day where you haven't fueled with appropriate fluids and whatnot. It's not worth being a hero here to change the outcome of your life and a bunch of other people's. So it happens, and it happens enough that we all know about it. So probably better to be safe
the other
sorry.
thing too is in that same journal, the American Journal of Kidney Disease, in the February 2016, there's another article which is peripherally related. It says Mesoamerican nephropathy: do novel biomarkers of kidney damage have a role to play? And basically, the article is about nephropathy or kidney, pathology in Mesoamericans, but it goes through to discuss a lot of the kidney markers or biomarkers that you're going to see in blood work that can cause, not necessarily cause damage, but are indicative of damage. And it talks in there is that some of these biomarkers really aren't that good. So on the same token, these things will go up, but it may not be nearly as bad as they're making it sound in Newsweek, which is where I believe the article appeared. They kind of talked about it there, and then they refer you over to the kidney journal.
Yeah, we'll have those in the show notes for you, but the link to the Kidney Journal is in the Newsweek article. And I was right. I mean, running's an easy one to pick on because so many people do it. It doesn't cost any money other than a pair of shoes and a trip out the door. But, it's one where people tend to push the limits a little bit, and it's on everybody's bucket list. And a lot of people don't do the appropriate amount of capacity and durability training to do enough. And how many people enter into the marathon not prepared with the proper mileage? They might have only done a 12 or 15 mile run, and all of a sudden it's a hot day and you got to do 10 more than you're used to, and you're not even used to fueling or hydrating properly on those days. Don't be a hero on those days. Approach this thing with a little bit of head smarts and give yourself a chance to hydrate properly and walk and take a break. And if you're overheating, you need to do something about it. So just something to think about. Nothing trying to scare you guys, but something to think about. So Elon Musk was in the news a couple weeks ago, and I pulled this one out. It was obviously, it's always good to see what that modern day genius is doing, but he's at it again, and he's basically bought up a company that has introduced a product called Neural Lace, Neural Lace, as in neurology, Neural Lace. And, he's big on the artificial intelligence and bringing together the integration of computers and silicon technology into the human mechanism here. And this is just one more case of where he's trying to beat out the digital progression of artificial intelligence into the human body. And this is basically a way of integrating those electrical neural circuits into the human body without via surpassing maybe a computer or a physical interface or something like that. So just interesting, because this certainly brings up the topic if you read into the article, and it's not really worth downloading or linking to it because there's not a lot in here. Ivan and I will discuss the germane points here, but if you look at a lot of the diseases that are hot and in the news these days, Parkinson's and dementia and Alzheimer's, these neurodegenerative diseases that have a cognitive decline capacity to them or component to them, this could offset that. I mean, we are all quite integrated with our cell phones. We want to know something, we just Google it, and it's in our hands within 10 seconds. If we can integrate some of that stuff into our central nervous system through a chip, people who have neurocognitive decline, whether it's memory or whatnot, we may be able to circumvent some of those things. And we've talked about other ways of doing that through implanting these chips adjacent to a vessel near the brain, It's one way to actually implant these things without having to do brain surgery. Linking it up to a computer, we talked about that for circumventing spinal cord injuries. And I'm not sure what podcast that is, but, the brain sends a signal, the chip picks it up, sends it over via Bluetooth to a computer. The computer then sends it via Bluetooth to another chip that's below the spinal cord injury, and all of a sudden the intention of moving the leg is now an active integration of moving the leg because of a Bluetooth circumventing through the spinal cord damage. And so in a similar fashion, maybe we're going to be implementing some of these things through Elon Musk's next little piece of technology here, the neural lace. But I don't know if it brought up any thoughts on your part, but we just like to bring these things up as always for you guys in the neuroscience piece, that damage to a limb from an injury, that it affects your gait and your activity levels. We may have ways around that other than amputation or prosthetics. In the more traditional ways that we are all used to it, there may be ways to get around it with technology. So, do you have any thoughts?
Not really. I think he covered it pretty comprehensively. It reminds me of a book by Larry Niven called The Long Arm of Gil Hamilton, which is set in the future, where they have these little electrical plugs that you can put in the top of your head to basically do things. Or the Matrix even. You can think about that whole being able to plug into somebody's brain. It's probably not really as far off as we think, and it's probably not as science fiction-y as we once believed. So, yeah, I mean, it is what it is, and maybe he envisions hooking this up to the car, the Tesla,
Yeah.
So you can just drive by sitting there and not having to do anything. I don't know.
Well, let's face it. I mean, we've seen, where I think we're on the second, maybe even third generation of the iWatch with, the heart rate and all these things, and now they've got contact lenses that are going to be able to detect temperature and heart rate, blood pressure, glucose levels. We know that they've got these patches that are doing, you just like a little silicone patch, you lick it and stick it, and it tells you where your hydration levels are, which may be germane to the first topic we talked about with the kidneys. I mean, if you're probably in your 40s and 50s right now, you're going to see some of this stuff, and you're probably going to have the opportunity to partake in some of these biohacks, if you will, to improve our life. And maybe eyeglasses are going to be a thing of the past, and just a contact lens will be something of the future that may allow you to telescope in and out like a camera lens. We've got a lot of things that are coming our way here, and they're certainly going to improve our lives. As some people talk about, the interesting point is going to be when someone decides to lop off a healthy limb to replace it with a bionic one that's way better than their human equivalent. That's when things are going to get a little funky and interesting here. But let's see how far we go, and let's see if we're around to see some of that. It certainly will be interesting, but I know there's a couple things that I will certainly look into for myself when the time comes, if I can stay healthy enough long enough to partake in these things. For me, it's vision, but I'm sure a lot of us are going to have some other issues that may allow us to get around them, whether that's a bionic joint from, imagine, and I think we talked about this, and I read it somewhere about, joint replacements like a knee or a hip, where they take out some of the significant ligament structures that have high proprioceptive capacity to them. If we can put a gyroscope in a phone, why can't we just slap one into a joint replacement and wire that into the central nervous system to give us some of that proprioceptive loss back into the central nervous system by getting that device to actually tell us more than just being a mechanical device in the joint, being one that is more proprioceptively, neurologically input into the system. So that's when things are going to get interesting, and I'm sure someone either has it or are working on it. I don't think I dreamt that one up, did I?
It'll certainly be interesting. The thing there is now you're going to have a sensor in a joint which provides way more information than what perhaps the receptor in the joint was supposed to supply in a different way, right? Because our understanding of some of the receptors and how they work is, primitive at best. So, it's interesting to see how that will become integrated, and will that create problems, or will we need to expand our brains to a greater degree to accommodate this greater amount of information that's coming in, Yeah.
It certainly will be interesting. this next generation of people younger than us are going to have a wild ride on their hands. That's for sure. A lot of options that we never had. So, hey, this is kind of germane to what we do. I was over at a CrossFit gym last Friday night giving a talk. And one of the students over there at the end of the session came up and she said, I'm having all this anterior hip discomfort, particularly after we do squats and especially deadlifts. And it's getting worse. And the first thing I noticed is that her posture was very much, it's as if someone had stood behind her and had just pushed her pelvis forward about 1.5 inches, 2 inches. Literally a sagittal forward translation. You know, you might call that a sway back posture or what have you, but she was clearly not having her pelvis underneath her thoracic cage. It was slightly anteriorward. And the first thing I mentioned to her was, you know, do you have pain on your deadlifts or your squats? And she said no, but afterwards there was some discomfort, some tightness in the hips and whatnot. That posture, particularly, imagine someone doing a real heavy deadlift. And, you know, they always teach you to kind of squeeze it out at the end and push the pelvis forward and really load up the posterior pelvis and get into the glutes. Well, that tends to strain the anterior hip joint capsule a little bit and maybe some of the anterior structures. But more importantly, what it does is it teaches a behavior that I don't really like, and I have to get people out of it quite often, gluteal gripping, if you will, where the glutes are under an incredible amount of tone, and they tend to push that femoral head forward in the acetabulum a little bit. And we lose that relationship, that harmonious relationship between the glutes and the hip flexors, particularly the psoas and the iliacus, to help centrate that femoral head in the acetabulum. And it's thought, and there's plenty of journal articles out there that discuss it, that this is one of the correlatives to anterior hip impingement and cam-type problems, that when this the femoral head is so far forward as you go into a squat position, if that thing isn't recentrated, you're basically squatting with that femoral head superior and anterior in that acetabulum, and creates an impingement or a pinching effect in the hip. And so proper hip hinging technique and in her case, just teaching her where the pelvis should have been, which is a more posterior translation with appropriate abdominals. Immediately she could feel the effect. And we did a before and after picture, and it was quite cute because the second picture, her, as she said, my booty's sticking out. It looks nice. And I said, I had to agree. It looked much better in the picture. The profile was certainly more attractive. But I said, more importantly, your hips are probably a little bit more centrated there, but we're going to probably have to do some some coaching with her trainer in order to get her out of some of these bad habits. And as it turned out at the end of the lecture, the owner of the gym who works with this gal said, how many times have I been telling you to do this? And one guy comes in and says something once, and all of a sudden there's an epiphany, which was kind of amusing. So obviously he's on top of it. He's become a good friend of mine, Nick, over at Ignite Fitness in Elmhurst. And boy, what a stickler for technique and positioning and doing appropriate warm-ups and everything. I can't recommend them enough, but it was just interesting that, that came up during my talk, and then all of a sudden, at the end, someone comes up with something that was germane to the discussion. Is that something that you see? I'm not sure how many people out in your neck of the woods are doing a lot of CrossFit and lifting, seeing as you're up at 10,000 feet there. But I'm not sure if you had any comments on this anterior hip discomfort and pelvic posturing and these types of Olympic and heavy lifts.
We see a fair amount of CrossFitters, and I take care of some CrossFit instructors and stuff, and I would say that, they're pretty much sticklers for positioning, but seeing people with this anterior pelvis, in other words, that whole pelvis is carried anteriorly in the gravitational plane, is relatively common. And in addition to what you said, I would emphasize that this sort of anterior femoral glide that you're seeing here occurs only when you have posterior rotation of the pelvis. So if you have anterior rotation,
tilt,
right, posterior pelvic tilt, it's only going to occur when that happens because of the glide and roll principle, during basic kinematics. If you have, and you're maintaining that lordosis, like McGill talks about and things like that, you're not going to run into that as much. The other thing I'd mention is that when your pelvis is that far anteriorly and we're loading it like with squat, and it's that little pelvic thrust that they do in the end, and yes, you do get increased gluteal activity at the very end. And what they don't mention is also with that push forward is, yes, you also get increased compression on the posterior aspect of your lumbar discs and facet joints, which are only designed to carry 20% of the load, and now you're making them carry a whole bunch more of the load because of the positioning. So it's not so healthy for the discs and the lumbar spine for that little pelvic tilt, even though you're getting that, extra blast of gluteal activity going throughout. In my opinion, you're much better rather than just emphasizing that. Because think about it, it's basically an isometric or very small isotonic contraction at the very end. So at absolute best, you're increasing your physiological strength 15 degrees, on the point of application at the end into extension. And are you really going to use that 15 degrees during a lot of activities? Well, judging from most of the runners that I see and sprinters and, even cyclists to that degree, people just don't use that range of motion, that end range of motion of hip strength. So to build asymmetrical strength in one end of the range of motion is, kind of silly. Especially if you're not going to be using it, unless, you are a professional pelvic thruster. So I can think of some professions that are considered noble in other countries but are illegal in others that perhaps this could be very usful for. But
you dirty man.
No, I'm just saying that. So yes, but I really would emphasize that you have to have a posterior pelvic tilt for this to happen. If you're maintaining that normal lordotic curvature and neutral or slight anterior pelvic tilt, you're not going to get that anterior translation. Sauerman talks about this a lot in her book with regards to anterior femoral glides and things like that. The other
Shirley Sahrmann or Sauerman?
Sauerman, Sahrmann.
Yeah,
Shirley. Yeah. Who I learned about actually through your office. One of your physical therapists had turned me on to her, and I really like that a lot. But anyway, that, and then the only other thing, and you kind of mentioned it peripherally, but just as far as you're going to get some degree of reciprocal inhibition, which is going to occur. So when we contract one muscle, you're going to get contraction of the opposite muscle. Now, I know we're always trying to emphasize gluteal activity to shut down the psoas during the early phases of hip extension, say from slight flexion to, say, 15 degrees extension. But when we get in a state where our lumbar spine and perhaps our hip is already in a much extended posture and we fire the glute, the psoas and the conjoined tendon of the iliacus with the psoas in that area provide protection to the anterior aspect of the hip joint. And if you are reciprocally inhibiting that, you're taking that away. So you're actually, depending upon the degree of version, or torsion may it be, of the femoral head angle, you're going to push that against the front of the capsule, and you can stretch the capsule, you can create cam and pincher lesions like you'd mentioned. So, again, technique, hammer at home, have people, do it correctly or don't do it at all. If you can't do it slow, you shouldn't be doing it fast. All of the things that we talk about all the time, that whole skill first, then endurance and strength last. And I have to say, treating a lot of CrossFitters, as I'm sure you do, a lot of them don't even have the skill. And they're doing they're skipping endurance and going right to strength. And that's why they're in my office. And it's great. Since CrossFit has started, my practice has really grown in a lot of ways. So it's been good from that perspective. But and I'm not saying CrossFit's bad. I think it needs to be done with a lot of attention to detail. And I think some people, especially the whole going to failure sometimes and things like that, like you might not be able to bang out 20 burpees with good form. You might only get 7. So do 7, and build on that rather than having crappy form through the last ones and then, creating other injuries. And that's just a beef I have because I see a lot of those injuries. And there are a lot of really excellent people out there doing CrossFit and excellent instructors, but there's also a lot of not so excellent or less than excellent instructors that are giving advice or not paying attention to things like leg positioning and femoral torsions and tibial torsions and foot positioning and body mechanics in general.
Yeah, I mean, you said a lot of really important things there. I'll just finish up with just a couple. I mean, that was the premise of my talk was, I mean, as soon as you start fatiguing and you want to continue a couple more reps because you're trying to beat someone out or you got a time to finish, you got a certain number of reps or you're trying to hit a PR number or what have you, that's where the injuries tend to occur when we start to fatigue and we start to now dump into compensatory movement patterns that may have abnormal loading responses and consequences to those responses. So, as you said, once you start to hit that fatigue and now you're doing, a muscle up or you're doing a bar up or you're doing a kip or something like that, or even a squat, and you start to notice that the asymmetry is kicking in, you're pushing a bar overhead and one arm is not driving that bar up. Okay, if you try to do one more, we got some potential problems, but even more so, you're building strength into that asymmetry and forcing some aberrant patterns into it. So even though we're talking about lifting right here, this is really, correlates strongly to runners because, and this is a task I do with my clients. I know you do too, and we've talked about this ad nauseum here, but it's worth mentioning again that clients who are into an anterior pelvic tilt cannot get into their glutes. So weak lower abdominals that aren't holding the front of that pelvis up are into a lumbar extension / sway back posture, and they can't get into their glutes. If you don't believe me, go ahead and stand up and try it. You cannot get into the glute position because the pelvis orientation in relation to the femoral attachment on the femur is inappropriate enough to be able to get even a remotely adequate contraction. So what do people do as they start to fatigue is they tend to go into a posterior pelvic tilt, and we have runners that do that. They're into a run and they feel their glutes fatiguing, or they maybe get some hip pain, and hey, it's easy enough just to kind of tip my pelvis back a little bit and get into more of a clenching response from the glutes as opposed to holding that position from the abdominals from the front. And it's why we just pound lower abdominal strength and holding pelvis neutral from the front as opposed to doing it through gluteal gripping or hamstring tension or chronic shortness from the posterior aspect below the pelvis. So if you're doing some lifting to try and supplement your running to improve upon it, you better be using good form. And so I have a rule in my office, whether or not it's valid or not, but it seems to work for me and it seems to help people. As I said, you're not allowed to do any more than 10 to 20% of your deadlifts and squats and whatnot at that terminal squeeze, which means if you're doing 10 reps, you're not allowed to do more than 1 or 2 of those reps during that set into that terminal hip, posterior pelvic tilt, shift, anterior shifting kind of terminal squeeze. That way, the majority of your lifts are clean, but you can certainly adopt a little bit of the benefit from 1 or 2, but I don't want that to be the dominant perspective or aspect of the lift, just to reduce some of your risk factors. And it seems reasonable, and it's a nice way to try and get your client to say, look, I'm not going to tell you not to do what everybody else is doing, but can we reduce the number of times you're doing it so that we aren't actually, running into problems here. So those are just some extra thoughts there.
And just piggybacking on that, I really like that 20% rule, and I use that all the time in the office, whether it's increasing weight, increasing endurance, increasing running, increasing mileage on a bicycle, whichever. We try to stay to let's not exceed 20% per week as far as time per workout, as far as distance per workout, and as far as effort per workout. And if people do that, they're basically doubling their current capacity, whatever you would like to call it, in about 5 weeks' time, which seems to be a really nice, steady growth rate, and it allows for way fewer injuries. I always tell people, look, you've done your hard workout. It's like you need some rest miles. So just, get on your bike, put it in a really low gear and just spin. Get your cadence up to 110, 120, whatever's going to work for you, and spin with very little resistance and concentrate on keeping that cadence constant, whether it's running or cycling. But I really like the 20% per week. We use that pretty much, definitely weekly, almost probably daily. As far as that goes.
Tends to be safe, whether it's 20% per set or 20% per week with gains and, all those things. It's a good safe number. It allows you to kind of push the system a little bit without adding risk. So several weeks or several months back, a lady from England emailed us, and I don't think.
Did she email with an accent?
Absolutely. Google does that now. And I don't think I ever forwarded it over to you because I didn't feel like either of us could help her, but her primary complaint was dystonia in the lower limbs. And I responded back. I don't remember exactly what it was. I could dig it up, but I don't think it's really important to our discussion here. But she emailed me back this morning, and it was rather positive, so I thought I'd share it because there's a couple points here that, with a little bit of information, which I think I furnished her with, a little bit of self-discovery with that information sometimes just hits the mark. So the email goes like this. Hey, Sean, I thought I'd touch base again as my improvement continues, and I think I've nailed the cause. I've had a mild leg length discrepancy and scoliosis since childhood, and I have worn orthotics sporadically since then, more often than not. I recently noticed that I stand habitually on a tipped pelvis with weight-bearing, so I'm assuming that's an anterior pelvic tilt, at least that's the way the rest of the email seems to suggest. On a tipped pelvis with weight-bearing slumped medially on my bad/longer leg, such that there's a noticeable crease where the inner thigh meets the torso on that side, hence why I thought anterior pelvic tilt. So it sounds like she's forward tipped on that side, which could correlate with some increased tone in the hip flexors and quads and weak abs, maybe a pelvic distortion pattern, but who knows. So who knows what kind of compression or deactivation was going on around the back as a result. So I started consciously straightening the femur on that side while standing so that the crease went away. In other words, I think she's reducing her pelvic tilt. Instantly, the rotators on the bad side were challenged and started to burn. And that's what we were just talking about. If you're into an anterior pelvic tilt, you can't get into your glutes. You go into a posterior pelvic tilt, in her case, reducing the crease, and all of a sudden she gets into her glutes, which she's never used, and immediately felt a burn, which tells me how weak they were. This felt right, so I took out the insole in my longer leg while running. For the first time in decades, I could feel the hip joint properly. At the end of yesterday's run, I felt a small muscle, maybe glute medius or quadratus lumborum, flicking on deep in her buttock and low back area. I'm now working on strengthening the stabilizers and rotators with standing on one leg, doing mini squats, etc. Hopefully this will do the trick. And then she goes on to her typical, and justifiable rant. Why wasn't this diagnosed earlier from someone? I expect that I, like most patients, diligently stand up straight during exams, and the trick is catching the bad stance before it can wreak havoc months or years later. So she was very grateful, even though we didn't do anything. I don't even remember what I said, but I'm sure I threw out without examining you, we can't help you, but how's your posture? It was probably something as benign as that. But nonetheless, she learned how to correct her pelvis and through just being aware and stacking the limbs, hip over knee, knee over foot, and foot over ankle, and then ankle over a neutral tripod. And typically when you do that, you probably end up having better biomechanics. And as you and I have talked about, the ankle and the hip are always having this dialogue of, how are you doing? We need to work together on this type of thing. But posture is big and important, but she does bring up an important point, is that, when we, it's like having the cleaning lady come over to your house, or cleaning man coming over to your house, and you clean up before they get there. And, you want to go into a doctor's office and they ask you to walk, and all of a sudden you try and do your best walk instead of the walk you always do. And when you ask them to stand, instead of standing the way they normally do with a attitudinal shift to one side and kind of bumping the hip out, they try to stand up correctly. She brings up a good point that patients might not always do what they're supposed to do in an office when you're trying to examine them. It's kind of like brushing your teeth before you go to the dentist. I mean, who are you trying to fool here? So, I don't know. Did this spur any thoughts? I just thought I would share it because it was a success story without actually us doing anything. So, it's always good to have a nice outcome like that. But ring any bells?
I think that she's just becoming more aware of what's going on with her body. When you get people to tune in, whether it's with gait, exercise, diet, any of those things, mindfulness, people have a tendency to notice more things and are able to make those corrections. From what she's talking about here, I'm thinking that her deep buttock muscle is probably some of the deep six, probably quadratus femoris, but it could be one of the others as well that's going there. And, it's the standard answer. Why wasn't this diagnosed earlier? And my standard answer to people is, I don't know. Did anybody look? And this is why you're here. And that's why our job as clinicians and coaches and doctors and all of those things is to exploit people's weaknesses. That's what we do. You're not here for me to tell you how good you are. You're here for me to help you to improve upon what you've got. So, doing those little tricks, watching the person as they're moving from the waiting room to the examination room, watching the way they carry their weight when they're just sitting there, watching the way they get up if they're putting more weight on one extremity or the other, watching the way they walk and ambulate, having them put their hands up over their head while they're walking, having them put their hands to the sides, having them close their eyes, having them walk barefoot versus with shoes on. Conducting your exam not only on the table but also in standing positions, trying to reproduce whatever their problem is. My general rule of thumb, and I think you probably use this too, is like, you come in to see me, if I can reproduce your pain and what's going on, I can probably help you fix it. If I can't reproduce it, then I don't know if I'm going to be able to do that. Save for people with GI discomfort and things like that. That's kind of how it is. So here's a gal that basically created her own awareness, which is awesome. And, more than likely with the fact that she got better, she could have a anatomical leg length discrepancy, or just the change to the system was enough to make her feel better. And it could have been any change. You could have stuck a pizza box on the other side. You could have, given her a different song to sing while she's, it's tough to say, again, without examining somebody like this, but we have lots of people that'll come in and it's like, yeah, when I wear the insole on this side, this hurts, but when I take it out and I don't wear it on one, but I just wear, my orthotic on the other side, I have a tendency to do much better. And, a lot of these people do have anatomical deficiencies that sometimes they're able to compensate for, and sometimes they need a little help, a lift, an orthotic, different exercise, whatever. But, you love to hear stories like this because it's like, wow, yeah, you figured it out, you got it, and you're moving forward. And that's great. And then, they come to see you weeks, months later, and now they've got shoulder pain or they've got neck pain or whatever. And it's just like we talk about, it's the layers of the onion. And, that was just one of the compensations, and now that one is corrected or different. So you've got a new compensation. And you're going to kind of unwind until we get back to where you need to be, or where you're relatively asymptomatic.
Yeah, I mean, how many times do you have that where a patient, you resolve their back pain, now they're in 2 months later with shoulder pain, like, God, you fixed my back, but now I got shoulder pain. What the heck's going on? And and then the question inevitably is, could this be anything related to us fixing that other thing? And a lot of the times it's, this is all an unwinding of your system. But full disclosure, full admittance on my end is that it was probably the second, maybe even, gosh, I hope not, but maybe even the third year of chiropractic school, where you probably did it. I know I did it. All of us were. You go into a soft tissue lab or a biomechanics lab, and they're doing some hands-on stuff, and they pick someone out in the class and they use them as a demo. And at the end, at one point I was asked, and I said, "Yeah, I've got this chronic low back pain." The guy turned to me and goes, "Well, everybody in here can see how sway backed and anterior pelvic tilted you are." And to me, it was like, I still remember it. It was a slap in the face. Like, what? Why didn't anybody tell me this? That's how little awareness I had of my own body. And that started a really fast, hard journey for me of going, I need to look at everybody. And I went home, looked in the mirror. I was like, oh my God, why didn't someone mention my crappy posture being in chiropractic school? But, if it could happen to me second or third year in chiropractic school, shame on me, by the way. Why can't it happen to someone with no background and having no idea how this, machine works, and yet being an owner of one? So, great little reminder that we all need education in trying to move forward with these, resolving these machines of ours. So you
don't always know until a lot of times somebody points something out.
Yeah.
It's that whole, I don't know if you saw that movie. It's still one of my favorites. It's called What the Bleep Do We Know? And it's basically a movie on quantum mechanics. But the movie goes through and, they weren't even aware of some of the problems that were there until somebody pointed it out. And they talk about the Indian looking at the shore and not being able to see the ship that was there because nobody ever pointed out that that's what a ship looked like. And it's just like the first time, I learned about tibial torsions and stuff like that. I was like, holy crap, how many people have I missed this on, my entire life? And, I felt terrible with people like that I had seen previously with knee problems and stuff. And when they came back in, I'm like re-examining, oh, wow, well, that's what was really going on, But that's why, I'm always, and you and, our readers, people that are listening, that's why we're always like seeking to learn more, because the more the better your toolkit and the more likely you are to see things. And I still learn. I mean, gosh, when I hang out with you and we're like, doing stuff, I can remember just hanging out at the airport when we were coming back from Texas doing the gig down there, and just sitting there watching people walk by, and you'd say something, I'm like, oh yeah, I didn't really notice that, and then I'd say something, you're like, oh yeah, I didn't notice that either. So it's just that constant, that constant learning and that feedback, and then learning about ourselves as well. Like you said, sometimes you can't see the forest for the trees. So,
well, that was like folks that shortly after you and I started doing more postings on orthotics and working with different people who did that kind of stuff, and 2 or 3 years later, after gluing all kinds of wedges and corks and varus and valgus forefoot and rear foot wedges on people, they come back in 3 or 4 years later with knee pain, and oh yeah, doc, with this orthotic you made me, I'm wondering if I just need some updates on it. And you take it out of the shoe and you're like, oh my God, what the hell was I thinking? I mean, you have internal tibial torsion, and I didn't even know what that was when I started gluing stuff to your insert. And it's just a reminder of how far we've come, and probably, admittedly, how far we have to go as research gets us a little deeper down the road here. But it's always humbling to, but that's kind of how you learn, by experimenting. And it's a humbling process. It's frustrating at times. I remember one day it was early in the morning, and I woke up, and I don't know what I was doing. I guess I'd just woken up or done some meditating, and I was in the bathroom and I was shaving. And I was thinking about a client I knew that was on my schedule first thing in the morning, and I couldn't figure out why every time they came in, they were having pain in a different area. And I remember shaving thinking, I just don't know what's wrong with this person. I am making the wrong diagnosis. Every time they come in, the pain is somewhere else, and they're loading differently. And I remember dropping the razor in the sink going, they're changing, dummy, because you're changing them with the homework and my treatments. And I thought, oh, this is a progression. There's just not one thing wrong with most people. There's a layer. And that's when I started going, oh, Jesus, this is going to get a little bit more of a gray science than I ever wanted it to be. I was being a black and white guy. I mean, I realized I'd picked maybe the wrong profession in some respects. Of everything we do is gray, variations of gray and tones of gray, not this black and white that I like, So anyways, but let's go on to a topic kind of related to that last lady. I think you and I see things very much alike. You seem to like leg length discrepancies, and do you tend to lean towards anatomic leg length discrepancies more than functional? I tend to think so, and someone came in my office the other day and asked that question, and I started me thinking about it. Do I treat more functional leg lengths than you do, or do you see things more appropriately, or at least up front, more as a structural leg length? Or do you see them as a functional but treat them as a structural by using lifts and orthotics as a therapy tool until you can address the functional? I know it's kind of a layered question, but I think it might help some of our listeners, because if one person had that question, I'm sure there's probably several. So how do you approach these things? Do you tend to see and dive towards a structural leg length, an anatomically short or long leg first, or do you approach it from functional but treat it as a structural at the beginning to try and give them some relief?
It really depends. I check everybody for a structural leg length discrepancy, or an anatomical one, as you like to call it. I check pretty much everybody for that, and depending upon what's going on, I may or may not address that. I mean, I think leg length, whether it's functional or structural, is very important, particularly in light of what you're seeing clinically during their walking, gait, if that's what they're in to see you for, or during your clinical exam. So I may treat a anatomical leg length discrepancy, and part of you got to think about, okay, so this person has an anatomical discrepancy. All of a sudden now they have this back pain that developed, over the last, couple weeks or a couple months or even a year or so. But the person's 50-something and they've had it their whole life. Well, the chances probably aren't that all of a sudden now they need a lift. But they may need a little bit of help temporarily till you can get them out of that compensation pattern that they're in now and back maybe to their older one or to a different one, so they're stronger. So I may take somebody with a functional LLD and I may use a lift temporarily. I may take somebody with an anatomical one and not use a lift at all, and I'll just use exercise. So it really varies. But I do look at that, and I look at movement of the pelvis a lot, how that's related to arm swing, pelvic tilt, unilateral versus bilateral pronation. So I take leg length discrepancies pretty seriously as far as that goes. And because I treat a lot of skiers, and, they'll come in and they've got, pain here in the knee or whatever, very, very typically we see by just putting a full-length sole lift underneath the liner of their boot, inside their ski boot, you can tremendously change their ability to turn. And my question, let's just take the example, the person has an anatomically short leg on the left. It's going to be way easier for them to initiate a turn going to the left than it is going to the right. And that's because that leg is longer. They're more on the inside edge of their ski and outside on the other, because they're, theoretically when they're going into a corner, they're more pronated on the right, supinated on the left, and they have an increased amount of distance to go to the opposite side. And they'll be like, how did you know I had trouble making right turns? It's like, well, look at the length of your legs, And we'll go through, and we may design an orthotic or just use a simple lift, or sometimes just simple wedges, like a full-length varus or valgus wedge, or sometimes we'll, because we have a lab just like you do, we can custom make whatever needs to be made, valgus in the rear foot, varus in the forefoot, or whatever we have to do to create a level surface. Because a ski boot, unless it's a telemark boot, is a static environment. You're putting the foot in a fixed position in some degree of ankle dorsiflexion, somewhere between 12 and 20 degrees, depending upon the cuff angle of the boot. And that's going to be, germane. I had a gentleman come in just, 2 weeks ago, basically unilateral lower back discomfort and medial knee discomfort, but only when he's going uphill. And he does a lot of what we call skinning. And skinning means putting these things on the bottom of your skis that allow you to basically climb uphill. And it's a big exercise thing that a lot of folks do here. And it turns out he has an anatomical leg length discrepancy from one side to the other. And because he was not compensated going up the hill, on the longer leg side, he was forced into more ankle dorsiflexion than he was accompanied, that he could actually have, or that was even available to him. So he had more problems on that side. So by simply putting a lift on the opposite side, he thought I was nuts. He's like, Doc, the pain's on my right. Like, what are you doing with my left side? It's like, look, just humor me, all right? Go out, do this tomorrow, call me, tell me how you do. And he didn't call the next day, but I saw him a couple days later, and he's like, wow, that made an enormous difference. I can't believe that by treating, the left side, that fixed the right side. And that's just how it is. Carl Lewitt, I think, had it right. He who treats the area of pain is often lost. And you need to look at the area of pain, and sometimes it's obvious. It's like, yeah, look, you have a punji stick sticking through the bottom of your shoe, and that's sticking into your foot, and that's causing your plantar pain. But sometimes it's something totally different in a whole another area of the body, and until you address that, and that's our job. We are detectives and unravelers. And that's what, you and I spend our day doing, stuff like that. So anyway, to answer your question in a very long-winded and roundabout way, yes, I look at discrepancies a lot. Yes, I think as little as 3 millimeters can be significant. Yes, I treat some stuff with lifts. I'll treat some stuff with orthotic. I'll treat some stuff just with exercise. Some I'll use all three. It really is on a case-by-case basis. And I'll take people sometimes with equal leg lengths, and I'll use a lift on one side because I'm trying to create movement or a distortion in a certain part of the body to get a joint moving. So let's just take, for example, let's say you have a fixated sacroiliac joint on the right-hand side, which is just not moving. We won't get into well, does the sacroiliac joint really move? Does it not move? I can show you research, that says that it does. I can show you research that says that it doesn't. I know when people have a hypomobile joint and we manipulate it, they get better. Is that placebo? Am I doing something? Can't really tell you. But people that have what I'm perceiving as a hypomobile joint on one side, I'll put a lift under that foot temporarily to basically force that joint to work more. And by getting it to move more, it takes the stress a lot of times off the opposite side. Or if they're hypermobile on the opposite side. So we'll use that. We'll use occasionally, not often, but occasionally we'll use an orthotic or a lift, maybe just a heel lift or just a forefoot lift, to create anterior posterior tilt of the pelvis in a certain direction. So there's a lot of tricks, and I have to say that I learned a lot of, these things, or the principles of inducing a problem in one area to correct a problem in a different area, from Dr. Chili, our good friend. And Paul would do that all the time with manipulation. He'd have an area that was hypomobile in one area and hyper in another. So what he would do is he would induce a pathomechanical lesion into the hypermobile area to create hypomobility, to force the hypomobile area to move more. And then a week or two later, you take that pathomechanical lesion back out, and the person does much better. So I do a lot of that. And that's why I tell people it's very important that you follow up. Because, and I tell them this is what we're doing. And, if we let this go, I know you're going to feel better. But if we don't correct this, then down the road, this is going to turn into a different problem.
Yeah, I do that sometimes with a kinesio tape or rock tape. I'll create an area into the to the one area to try and change the tone, even make it a noxious stimuli to try and do it. You mentioned Dr. Chili was saying so. My perspective, I used to teach about the sacroiliac joint around the country when I was in my residency, so I got knee deep or ankle deep or eyeball deep, if you will, into the SI joint. A lot of the literature at that time, and it still says that the joint may move anywhere from 1 to 3 or 4 degrees. So, it's arguable that you can't even palpate that. And so it's a joint that I don't think typically gets hypermobile, in my opinion, but I'm not saying that with a great deal of stone cold certainty. It's a joint that I think tends to be very subservient to the muscles that cross it and the pathomechanics that cross it, or normal mechanics that cross it. So it's an interesting discussion. But when it comes down to the leg length stuff, we've got a real difficult situation here, because really the only way to assess it with any degree of accuracy, and that's arguable in itself, is with the patient lying on the table. And, I've shown cases over the years where someone has a slightly atrophied glute on that side, and if you take that person, you have them lie on their back, that atrophied glute in itself, with the way they rest on the table, creates a pelvic distortion pattern, which can create a change of the way the hip sits in the acetabulum, and can give you a distortion of a leg length interpretation. But more importantly, I do look at those things on the table like you do, but then I tell the patient almost always, okay, now I'm going to have you stand up, and we're going to actually see how you load this thing. Because I see something, but that may be a representation of a compensation pattern that you have demonstrated over time and earned that is a problem, because you're not loading the two hips in the pelvis symmetrically, or you're not loading that pelvis on the low back on the pelvis symmetrically. So a lot of this, and I think you'll agree, comes down to how well do you load this, because you can load into a hip that's weak in the glute medius and glute max and glute minimus, and you can load into a Trendelenburg type shift in the frontal plane, which will essentially give you a distortion of a leg length discrepancy functionally. And if left long enough, when the patient then postures on the table in the supine or prone position, it can look like an anatomical leg length discrepancy. And the pelvis still may actually look flush on the table, like it's squared up, and yet the way they've postured that hip in the acetabulum may actually be a distortion. So you've really got to look at a lot of these things and keep kind of a wide open or jaundiced eye on how this really plays out, because we're only able to determine so much from palpation and visually without, a small standard deviation of error in one direction or the other. So I always tend to default to, let's just see how you're loading this thing first. And if you're not loading it well, let's figure out if we can get you to load it better. And then we'll give you some homework. And over a period of a week or two, we'll see how you're doing. And that's when I will intervene with a leg length discrepancy adjustment, meaning a sole lift or something like that. Very trivial, very minimal if I have to see if they need a little bit of a crutch to help them with that impaired loading response a little bit better until we can catch up to the other side. So I think that's why I tend towards more functional at the beginning, functional leg length discrepancy, because I want to make sure that I don't start padding something that I've interpreted, at least off the cuff, as an anatomic. And I think if I stood back and asked you that after the question after saying that, I think you'd probably agree. with everything I said there. Am I correct?
Yeah, I mean, we don't always, just because we see it immediately first visit, necessarily do that, but it stays in the back of my mind. And if things are not moving along the way that, I think they should, or the patient thinks they should, then we're going to look further, at that. But anyway, it is what it is.
Yep, it is. Yeah. So, well, we're already an hour into this. We can stop. We can save these 2 pieces for next time. What do you feel like doing, man?
I think we save them for next time, because I know when I personally listen to podcasts, if they're over an hour, I'm less likely to listen to it than if they're under an hour. So,
alrighty. You heard it from the man, folks. We're done. We're going to stop right there. No commercials, no fluff, no muss, no fuss. We're done. I'm Sean Allen in Chicago.
I have a whirl up in Dillon, Colorado. We will see you in the shoe aisle.